Hello, good evening, everyone. I
Good evening,
welcome
madam.
you all.
Good evening, sir. Mandra sir, good evening.
Yeah.
Heman sir, good evening.
Yes, Dr. Nijama.
I'm welcoming all of you on behalf of Maharashtra IIP. After Dr. Gangolia from our Raigad IIP has become president of Maharashtra IIP, this is our first activity in the month of February. The idea of this activity is suggested by Dr. Mahesh Mohite sir. He suggested there will be one mentor and 2 or 3 mentees or students of this mentor, and we will have a case-based discussion regarding one topic, so that the mentor will guide, judge, and guide us also regarding the topic. Now, today's first topic, we have decided about primary immunodeficiency, and for helping in understanding this concept, which is rather difficult, we have Dr. Sagar Bhattat, Dr. Rachana, and Dr. Avinash as mentor and mentees team. So we'll start with this activity. I welcome CIIP President-elect Dr. Upendra Kindavdekar sir, Maharashtra IIP President Dr. Hemant Gangolia sir, Raigad IIP President Dr. Pramod Wankhede are today's speakers, and I can see many of the Maharashtra IIP members, including Dr. Renu Boralkar, Chitra Madam, Kaustubh Mohite, everyone has joined. Welcome all. We'll start with the session. Now I'll request first Dr. Hemant Gangolia sir to address the meeting and proceed.
Thank you, madam. Namaste to each one and everyone. Respected dignitaries, our CIP President-elect Dr. Upendra ji, all the dignitaries, office bearers of Maha IP, as well as all Maha IPians, and on the Zoom dais, as well as on the Maha IP YouTube channel. This is the first episode of Maha Mentor Mentees, which was conceptualized by our Chairman Intensive Chapter, Dr. Mahesh Mohite sir, and was executed in our Maha Pedicon, third West Jot Pedicon and Maha Pedicon, which was held in November. And this we will be having 9 episodes throughout this year, and let us learn, and which will help us in our day-to-day practice from the difficult topics which will be discussed by the mentor and mentees, and wish each one a happy learning. Thank you each one.
Thank you, Hemant sir. Now I'll request Dr. Upendra Kindavdekar sir to address the meeting.
Namaskar, very good evening to each one of you. President of Maha IP, Dr. Hemant Gangolia, President of Raigad IP, Dr. Pramod Wankhede, my dear friend, Dr. Mahesh Mohite, and all esteemed colleagues present over here on and off the screen. So it's a great initiative. Dr. Hemant, I must congratulate you. Last year, we had started a pediatric update series, and I was happy to see Dr. Sagar as a opening batsman, the curtain raiser of today's mentor mentees program. What a wonderful choice to begin with, because we have heard him so many times in immunodeficiency topics. And the best part of this team, Dr. Rachana, also I heard her one or two videos, and amazing clarity of thoughts at such a young age and deliberation of message in simple words. So that comes from the mentor. So we have a great team. I'm sure Dr. Avinash and Dr. Rachana, with the help of Dr. Sagar, are going to guide us. So it's a good beginning, and I wish this program a great success. Great going. Thank you so much, everybody. And let's have happy learning for each one of us. Thank you.
Thank you, Dr. Upendra sir. Now we'll proceed to the session fast. Dr. Neha Singh from Raigad IIP will introduce our speakers for today.
Thank you, ma'am.
Neha?
Now for today's enlightening session of first Maha Mentor Mentees, we have with us Dr. Sagar Bhattat, Consultant Pediatric Immunology and Rheumatology, Aster CMI Hospital, Bangalore. Sir will be mentor for today's session. And as mentors, we have with us Dr. Avinash Sharma. He is MD Pediatrics and has done his DM in Pediatric Clinical Pediatric Clinical Immunology and Rheumatology from PGI Chandigarh. At present, he is working as Assistant Professor in Pediatric Clinical Immunology and Rheumatology at Dr. Rajendra Prasad Government Medical College, Kangra, Himachal Pradesh. He has 25 publications in national and international journals to his credit. And we also have with us Dr. Rachna Sambhag Mohite. She is MD Pediatrics, Fellow in Pediatric Immunology and BMT at Aster CMI Hospital, Bangalore. She has authored 8 publications in national and international peer-reviewed journals. I welcome all of you and hand over my mic to Dr. Sagar sir. Over to you, sir.
Yeah, good evening one and all, and thank you Maha IAP for this wonderful opportunity. I think this is a wonderful initiative, and anything around primary immune deficiencies will always interest me. And as a concept, I think Dr. Mohite sir wanted to introduce it as the mentor-mentee concept, but I would at the outset say Dr. Avinash is a great friend, a colleague, and I would say I have learned a lot from him. And as it goes, we all are in the learning phase, and let the learning continue. So let me first share the screen, and I'll give a brief introduction to today's session. So is my screen visible?
Yes, go ahead.
Yeah. So for the next 15 or 20 minutes, I'll briefly introduce the topic and see how 3 of us can sail through and produce some important concepts in primary immune deficiencies. Greetings from Aster CMI Hospital, Bangalore. And the topic today would be primary immune deficiency, why and what should I know? Now, whenever somebody talks about immunology, to make it interesting, I bring this cartoon that we all know that we are surrounded by pathogens, and there are leukocytes or white blood cells in our body which form the immune system and constantly protect us. So there is something known as the host pathogen battle that is an ongoing process. Though each of these bacteria or fungi is capable of causing infection and disease, disease is not a common occurrence. Now let me make this statement: disease is not a common occurrence, though we keep facing these pathogens in day-to-day life on a constant basis. So when do you get disease? There are several models proposed, and one of the model is that a disease would occur when you have a virulent pathogen, a susceptible host, and adverse environmental conditions or the stresses. Now, this has been a constant debate between, say, the intensivists, the ID experts, and the immunologists as to who plays the most important role. Is it the pathogen or is it the host? Now, when it comes to the virulent pathogen, we all know about the COVID virus, which has struck us for the past 2 years, and we have understood how a Delta variant was so different from the current Omicron variant. So this is a simple example to tell us how a virulence of pathogen can result in completely a different outlook for a given pathogen. Whereas Delta created a havoc, though Omicron is spreading, we all know it is now causing something known as a common cold virus. So the virulence of pathogen is of fundamental importance. However, equally important is a susceptible host. So if a host is susceptible, the same pathogen can result into a serious infection, and that is what we call an immune deficiency. And as a group, immune deficiencies can be both primary immune deficiencies and secondary immune deficiencies. But what we are interested to talk about is a group of genetic diseases, what is known as the primary immune deficiencies. For that matter, even when patients develop severe COVID-19, people have proposed defects in IFN interferon type 1 interferon pathways, which have resulted in severe COVID-19. That means severe COVID-19 itself can be considered as an immune deficiency in a susceptible host. So, a group of genetic disorders predisposing to infections, what we call the primary immune deficiencies. Now, a healthy immune system not only protects us against infections, but one must know that a competent immune system keeps cancer cells at check. Mutant cells are constantly being deleted. Also, a healthy immune system is self-tolerant. That means our white blood cells usually do not attack self. It would mean that if somebody has got an immune deficiency, they would not only be predisposed to infections, but would get predisposition to cancers and autoimmunity. And that is why the right term to these diseases would be the inborn errors of immunity. The current classification of primary immune deficiency states they are better to be called as inborn errors of immunity. And you would see in the years to come, we would not be discussing them as primary immune deficiencies, but as IEIs, the inborn errors of immunity. It is very interesting to note that these patients can have infections on one hand and autoimmunity on the other. And I thought of an interesting way of putting this, the spectrum of inborn errors of immunity, on one hand, low immunity, on the other, autoimmunity. So the questions for the day are, why should I know about PIDs or the inborn errors of immunity? As a pediatrician, as a busy physician, can I diagnose them? What if I diagnose them? Can we treat them? Do we have the wherewithal? Can we prevent them because these are genetic diseases and would recur in the same family again and again? And most important question that I've faced many occasions when I've given a talk on immune deficiency, can I refer a simple book? Are there brief videos which we can watch and develop our principles while we diagnose and treat immune deficiencies? Let us answer these questions one by one. Why should I know about PIDs? This is because these are not rare diseases. These are common diseases. Most of us are missing them. And because majority of them are genetic in origin, these would keep affecting more and more children in the same family. So if you as a family pediatrician are treating a family, and if the index child goes undiagnosed, there is very high likelihood that this family is going to suffer with more children being affected in days to come. How common is this? As a group, these diseases are as common as 1 in 1200 people. So these are not rare diseases. And as per the Indian Society for Primary Immune Deficiency, ISPID, it has been stated that if you take this number in India, it is estimated that there could be more than 1 million patients with primary immune deficiency in India. And what is actually getting diagnosed may be a few hundreds. So there is a lot that needs to be done. And these sessions would definitely be an eye-opener to many. Now, do you know PIDs as a group are 4 times more common than hemophilia? They are 5 times more common than cystic fibrosis. So hemophilia, or for that matter, cystic fibrosis, is so often discussed. Whenever you discuss a child with recurrent infections, especially during our pediatric training, cystic fibrosis is so much talked about. I think we should be talking more about immune deficiencies in this setting. Now, these human inborn errors of immunity, as per a recent update on the classification given in 2019, they are as a group more than 430 diseases, not a single disease, and 64 new gene defects were identified only in the last 2 years, thanks to the advancement in molecular science and in next generation sequencing technologies. What it means is that this book is only going to expand, and I would not be surprised that in days to come, you may have 1,000 diseases to deal with. And that is why it is very essential to keep ourselves updated regarding this expanding science. Now, as you can see, way back in 1980s, there would be only 50 immune deficiencies that were well described. And in 2019, this number has crossed 400, and this would only keep expanding. Now, for pediatricians, I would say it would be very important to have a pragmatic classification when you see a child coming to you with recurrent infections. So one would like to classify them into B cell defects, the combined defects where the T cell is at dysfunction, phagocytic defects, and the complement deficiency. And as a broader group, as you can see, the most common deficiencies here are X-linked agammaglobulinemia and common variable immune deficiency. Combined immune defects would be severe combined immune deficiency, Wiskott-Ulrich syndrome. The phagocytic defects would be chronic granulomatous disease and neutropenias. The complement deficiencies can predispose you to Neisseria infections, especially if it is a terminal complement pathway defect, whereas early complement deficiency predispose you to lupus. The next question, can I diagnose them? Yes, we all can diagnose them by looking at the following warning signs, by developing an understanding of the pattern recognition, and by thinking of them. So once you start thinking of these diseases do exist, and you all will diagnose them in your day-to-day practice. The first warning sign would be a pneumonia, a recurrent pneumonia, say 2 or more episodes of pneumonia within a year, or non-resolving pneumonia one should think of an immune deficiency. In the same go, recurrent diarrhea or chronic diarrhea that does not resolve, one should think of an immune deficiency. Failure to thrive, one should think of an immune deficiency. Presence of unusual opportunistic infections like oral thrush, or as you can see in this picture, onychomycosis, fungal infections affecting the nails. Such infections, if recurrent, persistent, warrant an evaluation. Presence of suppurative infections like suppurative lymphadenitis, presence of liver abscess or lung abscess, osteomyelitis. Such suppurative infections should make one think of an immune deficiency, especially the phagocytic defects. Presence of unusual complications to live vaccines, like this child who is having a swelling over the, as you can see, axillary region, the cervical and the submandibular region, and this was the BCG site. This is a BCG ulcer. This child had disseminated BCG. So whenever you see disseminated BCG is a clear warning sign. Children coming to you with chronic eczema and recurrent infections, like in this case, recurrent cutaneous infections along with eczema is a warning sign, and a positive family history. Having a history of a sibling death or death of close family members with unusual or recurrent infections should make one think of an immune deficiency, because these are genetic disorders and unless diagnosed, they tend to recur. Pattern recognition. So as you can see, as a broad group, I can say there are B cell disorders, combined defects and phagocytic defects. And in fact, in today's session, we are going to touch upon these three common groups of immune deficiency. And the B cell disorders predominantly present with recurrent sinopulmonary infections. So somebody coming with recurrent sinusitis, recurrent ear discharge, recurrent pneumonia with common organisms like strep pneumonia, H influenza should make you think of a B cell defect. On the other hand, combined defect, a disorder where there is primarily a problem with the T cells, will produce opportunistic infections like recurrent fungal infections, viral infections, should make you think of a combined defect. And then suppurative infections, as I presented in one of those slides, should make you think of the neutrophilic defects or phagocytic defects. Can we treat them? Yes. Right now, treatment is available to majority of these in majority of these immune deficiencies. The B cell disorders need immunoglobulin infusions, and intravenous immunoglobulin infusions right now is available across the country, and in several states, free IVIG infusions have been provided by the state government. And then as a curative treatment in many of these immune deficiencies is the bone marrow transplant, and several centers now are coming up offering bone marrow transplant and curing these children. These are some of the pictures from the unit highlighting how we can cure these children. This is a child with chronic granulomatous disease who received transplant from the mother and got better. This is another child with severe combined immune deficiency who traveled all the way from Kolkata, got transplanted and got better. This is a child from Calicut who had chronic granulomatous disease, received transplant almost a year ago and got better. I am highlighting, or I am trying to present these pictures to give you a real life experience that these children can be transplanted and can be cured. Can we prevent them? I distinctly remember it was a year ago when this child was admitted in our PICU. This child had a serious immune deficiency, severe combined immune deficiency. But when he came to us, he had severe pneumonia, ARDS, was put on ventilator, multiple inotropes. We could not save this child. But what we ensured was we sent a genetic test. The genetic test came positive. We counseled the parents that we can do antenatal testing in the next pregnancy. In the next pregnancy, an amniocentesis was performed, and only the last week, the uncle called up and shared this picture of a beautiful child and said, we are thankful to you that you made sure that the first child, despite being serious, was diagnosed. And since we got a genetic diagnosis, we are now in position to get a healthy baby, and we are all happy. Now, this is what we can make a big difference by diagnosing these patients. Only by diagnosing these patients genetically can we offer them genetic counseling, genetic testing, and prenatal diagnosis. Now, can I refer a simple book, or do you have some videos on immune deficiency? Now, why I'm talking about this? This is because for the past 4 to 5 years, I have been talking on immune deficiencies in several congresses, and few common questions from busy practitioners and medical students that I often get is there a small and handy reference book for immune deficiencies? Is there a book that discussed real life case-based scenarios on immune deficiency? Where can we quickly refer for normative data for immunological tests? One should know that whenever you order an immunoglobulin profile, you should always look at the age norm before interpreting. then where should we refer for that? What samples need to be sent for immunological investigations? I realized although there are large voluminous books on immune deficiencies, a simple book that a pediatrician, that a medical student would love to was a necessity. And that is where I try to pen down a small book on immune deficiencies. This is a handbook for practicing pediatricians, physicians, and medical students, a 150-page book, a small book where you have normative data and case-based scenarios. And I'm sure busy pediatricians, medical students would love this book and children would get diagnosed early. It was equally important as I started presenting immune deficiencies in congresses, people would ask, we need to revise them. Although it looks interesting, but we often forget. And because these diseases are not dealt by pediatricians on day-to-day basis, it is very essential to go back and see how we can diagnose them. And that is where we got the concept of setting up a YouTube channel on immune deficiencies and started making brief 4 to 5 minute videos on variety of immune deficiencies. And I think these can be referred to whenever necessary. We also came out with a podcast series on primary immune deficiencies, and many pediatricians have appreciated it. In their times of leisure, they can listen to it. We also realize that it is important to create more doctors, more fellows in this subspecialty. And that is where, in association with an American organization, FPID, the Foundation for Primary Immune Deficiency, we set up the FPID Astor Fellowship in Pediatric Immunology in BMT, a 2-year course. And we are happy to have Dr. Rachna Shanbag Mohite, our first fellow who joined us in April 2021. She has been very proactive, and now I would definitely recommend her videos for all pediatricians who would like to diagnose immune deficiencies. Simple case-based discussion. Rachna has again set up a very good YouTube channel wherein individual cases have been discussed in depth, and I would strongly recommend all pediatricians to watch these videos. FPID, the Foundation for Primary Immune Deficiencies, based in US, has set up several centers of excellence in immune deficiency across India. We are at Astor CMI, one of those centers of excellence. They did an interesting job last year. They got all these centers together and asked them to publish data, multicentric data on primary immune deficiency. And as you can see with their efforts, several immune deficiencies, multicentric data have now been published. This was a paper on severe combined immune deficiency, a total 277 cases. X-linked agammaglobulinemia, close to 145 cases. Leukocyte adhesion deficiency, 132 cases. CGD, chronic granulomatous disease, 230 plus cases. Hyper IgE syndrome, 100 plus. MSMD, 100 plus. And autoinflammatory diseases, a new group of diseases, close to 55. As you can see, these diseases are now getting diagnosed, and more than 1,000 patients are at least being published across this data. However, we all should realize that this is only tip of the iceberg. What we have diagnosed is only the tip, and a huge number remains undiagnosed. Why is there underdiagnosis? This is because of lack of awareness, because many people still believe these diseases only exist in textbooks. Lack of diagnostic facilities, lack of trained doctors, believe that the diagnostic tests are very costly, out of reach, and then there is no treatment. Let me reassure you that diagnostic tests are now readily accessible in many of the cities, and they are not costly, they are very cost effective, and more treatment facilities are now available. The purpose of today's meeting is to highlight that immune deficiencies are very common. Every pediatrician and physician has encountered several cases of these diseases in his or her practice. Simple tests can diagnose these diseases. Tests are readily available and are cost effective. Most children can be treated, and many can be cured with bone marrow transplant. In the coming years, please believe me, thousands of such patients would get diagnosed. And as pediatricians, we should be at the forefront to diagnose and to offer therapy to them. In this session, I have the opportunity to introduce Dr. Rachna Shanbag, our first fellow who will be talking on B-cell defects. I'll quickly take you through T-cell defects then, and then my close friend and colleague, Dr. Avinash, would talk on phagocytic defects. We would try to present cases and highlight how these common groups of immune deficiencies can easily be diagnosed in clinical practice. Thank you.
Wonderful introduction, Dr. Sagar. Actually, what we wanted, you only put forward, and now we are very enthusiastic to listen to Dr. Rachna. Over to you, Doctor.
Is my screen visible?
Yes, go ahead.
Very good evening to one and all. To begin with, I would like to thank Maha IAP for giving us this opportunity to present today. And it is truly an honor because so many people attending the session on an evening, and also because so many of them have been my teachers and I have learned so much from them over the years. And I hope I do justice to this session. So today I'll be discussing the B cell defects, and it will be a clinical based approach. As Dr. Sagar highlighted, we know that the immune system has four main components. That is the B cell, the T cell, phagocytes, and the complement pathway. Out of all these, it is the B cell defects which are the most common. We also know that the B cells are responsible for producing immunoglobulins in the body, and these are the IgG, IgA, IgM, and IgE. But where do these B cells come from? We know that the bone marrow has stem cells, and the stem cells then produce the B cells. B cells, on encounter with pathogens and on stimulation, produce plasma cells, and these plasma cells then form IgM, which undergoes class switching to produce IgG and the other types of antibodies. So through the next few cases, we'll be discussing about different B cell defects and how each B cell defect affects a part of this pathway. So to begin with, we have a 4-year-old boy who presented with the chief complaints of fever for 6 days, cough for 5 days, and difficulty in breathing for 2 days. As we can see in the chest X-ray, this child has presented to us with bronchopneumonia. When we inquired in detail and when we asked about his past history, we found that this child had been unwell right from an early childhood. As we can see, at 18 months, this child has had an episode of bilateral otitis media. At 2 years, he's suffered from diarrhea. And between 2.5 to 3.5 years, he's had 2 episodes of pneumonia. So now he has presented to us with recurrent episodes of pneumonia, and during each episode, he was hospitalized for 8 to 10 days and treated with IV antibiotics and oxygen therapy. I'm sure as pediatricians, this is a very common case that we come across. And whenever we come across children with recurrent pneumonia, few differentials that we often think about is congenital heart disease. Hence, an echocardiography was done, which was reported to be normal. Then a lung anomaly and lung infections are a common possibility in this child, and a bronchoscopy and CT chest was also done, but did not give any answers. Since cystic fibrosis can also present with recurrent pneumonia, this child had undergone sweat chloride test, and that was normal. GERD is another possibility, hence a nuclear scan for GER was done, and that was also normal. Patients with HIV, we know, present with recurrent infections, and hence a HIV rapid card test was done, which was non-reactive. Let us have a look at his family history. He had a very significant family history where we can see that he has lost 2 male siblings at an early stage in life due to recurrent infections. And on his maternal side, there is history of death of 2 male uncles during a very young age, again due to infections. So now we have a child, a boy, who presents to us with episodes of recurrent pneumonia, past history suggestive of recurrent infections, and a family history suggestive of X-linked inheritance. So let us go ahead and look at his investigations. When we had a look at his complete blood counts, we saw that he was having neutrophilic leukocytosis. However, this was not guiding us to any diagnosis. Since primary immune deficiency was a possibility in this child, a simple immunology workup or an immunology screen was performed, and we performed an immunoglobulin profile. And as we can see here, his IgG, A, and M, all the levels were below the normal limits for his age. That is, this child was having pan-hypogammaglobulinemia. Moving on to his lymphocyte subsets. Now we do lymphocyte subsets to look at the T cell, B cell, and the NK cell counts. T cell is represented by the CD3 marker, B cells by CD19, and NK cells by CD56. And as we can see, this child has absent B cells. So now you have a boy who has presented with recurrent pneumonia with X-linked inheritance and low immunoglobulins and absent B cells. And the diagnosis was X-linked agammaglobulinemia. And when we performed a genetic test, it confirmed the diagnosis with a mutation in the BTK gene. So what is the message that we get from this case? That recurrent pneumonia and sinopulmonary infections, one must order a serum immunoglobulin level. Also, we must know that whenever we interpret these immunoglobulin levels, we must look at the age norms. To give you an example, if you have a child between 1 to 5 years of age, the normative values are between 345 to 1236. Whereas in adults, the values are between 639 to 1349. So imagine if you have a child who's 5 years old and presents to you with a immunoglobulin value or an IgG value of 500, and you were to compare it with the adult normative values, you would think that this is low. But for his age, it would be normal. So whenever the labs give us a serum immunoglobulin report, we must look at the age normative data to confirm whether the value is below the normal limits. Let us move on to another case. Now we have a 5-year-old boy, and this boy has presented to us with joint pain and swelling for 6 months. Knees, ankles, and several small joints of his hands were involved, and this child was provisionally diagnosed to have polyarticular JIA and was started on naproxen and methotrexate. Let us look at his past history. Now, this child has been suffering right from the age of 7 months. At 7 months, he had an episode of pneumonia. At 15 months, he suffered from otitis media. At 2 years, he's had diarrhea. And at 5 years, he has presented to us with pneumonia. And now he presents to us with involvement of multiple joints. Let us look at his investigations. The total counts are 10,900. But if you look at his neutrophil counts, the neutrophil value is only 9% with an ANC of 981. That is, this child was noted to have neutropenia. When we did the immunology workup in this child, we found that the serum immunoglobulin profile was again showing hypogammaglobulinemia. That is, if you see the IgG, A, and M levels are all below the normal range for his age. Let us look at his lymphocyte subsets. Now, the T cells are normal, whereas the B cells are 0%. That is, again, we have a child with absent B cells. As we saw from the previous case, a boy child presenting to you with recurrent pneumonia, low immunoglobulin levels, and absent B cells, the diagnosis is very clear. That is, it is X-linked agammaglobulinemia. So the message here is arthritis can also be a presentation of X-linked agammaglobulinemia, and neutropenia with recurrent infections, one must order an immunoglobulin profile. So what is X-linked agammaglobulinemia and where is the defect? We know that the B cells come from the bone marrow, and if there is a defect in the bone marrow and the bone marrow is not able to produce B cells, that is when we get the disease known as X-linked agammaglobulinemia. That is why these children have absent B cells and low immunoglobulin levels. So X-linked agammaglobulinemia, also known as Bruton's agammaglobulinemia, boys are affected, and these children present with recurrent pneumonia, otitis media, diarrhea, and skin infections. When we have a closer look at their oral cavity, they have absent tonsils and low immunoglobulin levels and absent B cells. And the mutation is in the BTK gene. And these children do well if they are put on monthly IVIG infusions. We have close to around 10 to 12 children who come on a regular basis to take IVIG monthly, and they do well and do not suffer from recurrent infections if they continue to take the therapy on a regular basis. Now, we often feel that PID is only present in early age, and often the children are the ones that are affected. But let us find out that can adults also have a PID? Let's look at this case. Now we have a 35-year-old gentleman, and this gentleman has been unwell for past 18 years, and he has presented with repeated episodes of pneumonia. He's had 10 episodes of so far, and he has been hospitalized on multiple occasions and treated with IV antimicrobials. Look at his past history. He's had recurrent infections from a young age, where he suffered from recurrent sinusitis and recurrent otitis media. And he's been treated on each occasion with antibiotics and antihistaminics. A CT chest was performed since this gentleman was suffering from recurrent pneumonia, and the CT chest was showing presence of bronchiectasis. When we performed an immunoglobulin profile in this gentleman, we found that the IgG, A, and M levels were low for the normal levels for this gentleman. That is, this man was having panhypogammaglobulinemia. Let us look at his lymphocyte subsets. The T cells were within the normal limits, whereas the B cells, if you see, They are also in the normal limits. Unlike the previous two cases where we discussed low immunoglobulin levels and absent B cells, this gentleman has presented to us with recurrent infections, low immunoglobulin levels, but normal B cells. So whenever you have an adult presenting with recurrent pneumonia and sinusitis, with a presentation of hypogammaglobulinemia and normal B cell counts, the diagnosis is common variable immune deficiency. Before we go on to what is common variable immune deficiency, let us discuss another case. Now we have a 55-year-old woman, and this woman has presented with repeated episodes of diarrhea for the past 5 years. She also complained of reduced appetite, and she had lost almost 10 kg weight due to recurrent episodes of diarrhea. And again, she was treated on multiple occasions with antibiotics with only partial response. Let us look at the investigations that she has undergone over the past few years. The CPC on multiple occasions were reported to be normal. Stool culture was sterile. HIV rapid CAR test was also done, which was non-reactive. And an endoscopy was done, which was inconclusive. Now, this woman presented to us with this kind of presentation with recurrent diarrhea with no diagnosis. Look at her immunoglobulin profile. As you can see, IgG, A, and M all are below the normal limits for this woman. That is, she is having panhypogammaglobulinemia. Let us look at the lymphocyte subsets. The T cells are normal, the B cells are also normal, and the NK cells are also normal. That is, she is having panhypogammaglobulinemia with normal B cells. So to summarize, a 55-year-old woman presenting with recurrent diarrhea, hypogammaglobulinemia, and normal B cell counts, the diagnosis is again common variable immune deficiency. And now, what is common variable immune deficiency? It is the commonest symptomatic immune deficiency seen in adults. They present with recurrent pneumonia, prolonged diarrhea, and weight loss. They have low immunoglobulins and normal B cells. Gastroenterologists and pulmonologists often come across these patients, and they must think of a diagnosis of CVID while dealing with these patients. And the treatment is monthly IVIG and prophylactic antibiotics. Coming back to the same diagram, where is the defect in CVID? It is in the formation of plasma cells. That is, the B cells are being produced by the bone marrow. However, they are not able to convert into plasma cells. That is why the B cell counts will be normal in these patients, whereas the immunoglobulin levels will be low. So the message here that we would like to convey is recurrent pneumonia, sinopulmonary infections, and diarrhea in adults, one must perform a serum immunoglobulin level. Moving on to the next case. Now we have a 12-year-old boy, and this boy has presented to us with recurrent rhinosinusitis since childhood. He's also had repeated pneumonia requiring 3 hospital admissions and treated with antibiotics on multiple occasions. Look at his blood culture. On one occasion, they have isolated Streptococcus pneumonia, whereas on another occasion, we have found Haemophilus influenzae. Now, what is peculiar about both these organisms is that they are encapsulated organisms in a child presenting with recurrent infections. Let us look at his immunoglobulin profile and lymphocyte subsets. Now, the lymphocyte subsets were normal and immunoglobulin profile was also normal. That is, his basic immunology screen was normal in this child. However, when a child presents to us with recurrent infections, and especially infections with encapsulated bacteria, we must think of subclass deficiencies. Now, the immunoglobulin or the IgG levels are normal in this child. But when we went ahead and performed IgG2 levels, we found that this child was having low IgG2 levels. For IgG2 levels, whenever we get low, for them to be significant, we must perform a anti-diphtheria toxoid IgG. That is, you give a diphtheria toxoid vaccine and 4 weeks later, you check the response to it. If the response to the vaccine is also poor, that confirms that the presence of low IgG2 levels is significant in this child. So now we have a 12-year-old boy with infections with encapsulated bacteria, normal immunoglobulin levels and normal B cell counts, low IgG2 levels. And when we check the antibody responses, they were also poor. So the diagnosis here is IgG2 subclass deficiency. IgG2, we know, is essential in immune response against encapsulated bacteria such as the pneumococcus and influenzae. IgG2 deficiency presents with recurrent upper and lower respiratory tract infections, and patients with IgG2 deficiency can be IgA deficient. The post-vaccination antibody titers is essential to define clinically significant deficiency, and the treatment here is essentially antibody prophylaxis, vaccination with conjugate pneumococcal vaccine, and monthly IVIG if the infections persist. So the message here we would like to convey is recurrent respiratory infections and normal immunoglobulin levels. One must look for IgG2 deficiency. Coming to another interesting case, we have a 4.5-year-old boy hospitalized with the 4th episode of pneumonia. He's required mechanical ventilation for 10 days, and he was referred to the pediatric immunology services at Aster CMI Hospital, Bangalore. When we had a look at his immunoglobulin profile, we can see that the IgG levels are low, IgA levels are low, and IgM levels are high in this child. That is, he's having high IgM levels. When we looked at his lymphocyte subsets, we found that he had normal B cell counts, and T cell counts and NK cell counts were also normal in this child. So whenever we have a 4.5-year-old boy with recurrent pneumonia presenting with high IgM levels, with low IgG and IgA, but normal B cell counts, the diagnosis here is hyper IgM syndrome. And the genetic mutation in this child was CD40 ligand deficiency, which is an X-linked disorder. What is hyper IgM syndrome? It is a defect in class switching from IgM to IgG and IgA. Now we know for the B cells to function in the body, it requires the help of the T helper cells. Now the T helper cells, with the help of CD40 ligand present on them, interact with CD40 present on the B cells. And this helps the B cells to convert IgM to IgG, that is, helps in class switching. So if there is a defect in the CD40 ligand, the T helper cells are unable to interact with the B cells, and that is when we get a syndrome known as hyper IgM syndrome. And they are characterized by normal or high IgM in the presence of low IgG. So the defect here is in class switching, that is conversion of IgM to IgG, and this is what is known as hyper IgM syndrome. They present with recurrent infections from early childhood, such as pneumocystis gyrovasii and cryptosporidium. Biliary tumors can also be seen in these children in the 2nd and 3rd decade of life, and the treatment is monthly IVIG and antibiotic prophylaxis. So coming to this slide, we discussed several B cell defects through various cases. X-linked A gamma globulinemia, we know, is a defect in production of B cells. Hence, they present to us with absent B cells and low immunoglobulin levels. CVID, on the other hand, usually presents in adulthood with infections like recurrent pneumonia and recurrent diarrhea. And the defect is in conversion of B cells to plasma cells. Hence, they will have normal B cells but low immunoglobulin levels. And finally, hyper IgM syndrome is a defect in class switching. Hence, the IgM levels are high, whereas the IgG levels are low in these patients. So to summarize, B cell defects, the onset of symptoms is usually after 6 months of age. They suffer from recurrent sinopulmonary infections, and that is when one must think of a B cell defect. Simple tests like immunoglobulin profile help in diagnosis, and we must always interpret these immunoglobulin levels according to the age norms. Whenever we have a young boy presenting to us with sinopulmonary infections, one B cell defect that we must think of is the X-linked A gamma globulinemia. Recurrent infections in an adult, think of CVID. Normal immunoglobulin levels does not rule out a PID, and one must look for a subclass deficiency. As it is always thought that PID-related tests are costly and difficult to interpret, through these case-based discussions, we have realized that simple tests like immunoglobulin profile and lymphocyte subsets can help us diagnose these conditions. Thank you.
Thank you, Dr. Rachana. It was wonderful, crystal clear and lucid presentation. जो समझना चाहिए था वो बराबर समझ में आ गया. So we'll proceed to the next speaker, Dr. Sagar.
Thank you. I think there are certain questions in the chat box which we can take.
Should we take at the end or?
There is one important question that we can take up right at this moment. I think they ask Can we send
So can we send
immunoglobulin?
immunoglobulin levels when the child is infected or admitted? That time can we do that?
Rachna, you want to take up that?
Yes, sir. So we definitely should send immunoglobulin levels during active infections. As during active infections, we know that our body is fighting these infections and is producing large amount of immunoglobulins. So if during these conditions, these times, if the immunoglobulin profile shows you low immunoglobulin levels, that points towards a PID. So one must always send immunoglobulin levels even during the times where the child is having active infections.
Dr. Sagar, you can take important questions if you feel in the chat box right now, if you feel.
Yeah, so there is another question in IgG2 subclass deficiency. Is pneumococcal vaccine effective? Now I'll try to take up that question. So IgG2 subclass deficiency is something that is not very commonly recognized because we don't often have these subclass levels easily available. But as Dr. Rachna rightly highlighted, that IgG2 is something that protects us against encapsulated pathogens. So the first treatment in IgG2 deficiency would be to give a pneumococcal vaccine, yes, but it has to be a conjugate vaccine followed by the polysaccharide vaccine, because once you conjugate it, the protein response often in many of these patients is very good. So the first step is to give the conjugate vaccine followed by the polysaccharide vaccine and see if they can fight these infections. And if they fail to fight, the next line of treatment will be IVIG.
Dr. Rachana, I have one question. Whether we should go by immediate whole IgG, IgM, IgA level immediately, or whether go for first IgA level, check it. With the normal abnormals, go for IgG, IgM. What will take on this?
Sir, I would recommend, or rather what we have been practicing is we definitely send the entire profile, because that also helps us to know what all the immunoglobulins are. So they cannot be interpreted individually. So if you've already sent the IgG, A and M and E levels, you would know if IgG, A, M all are low, then that would give you a better diagnosis rather than sending it one by one.
Dr. Nilima, please continue. It is to the total discretion to Dr. Sagar if he wants to take up the question right now. Otherwise, we will complete all the presentation. Please,
Yes.
Nilima, madam.
Dr. Sagar, you can proceed to your presentation now, and we'll go for the questions later.
Sure, ma'am. So I hope the screen is visible now.
Yes, it's visible.
Yeah. So after a very lucid discussion on B cell immune deficiencies, I'll quickly take you through the T cell deficiencies. And again, this shall be a case-based approach, highlighting how we can all diagnose the T cell deficiencies. Now, when should I suspect a T cell deficiency? How can one quickly diagnose severe combined immune deficiency? And let's have a case-based discussion. It is important to understand that once you have understood the B cell group of disorders, which presented predominantly with bacterial infections at a later age, T cell deficiencies often are serious immune deficiencies, and most often they are medical emergencies, and that is why we need to diagnose them early. Now, to make this interesting, I thought I'll present a story, a real life story of Mr. David Vetter. This boy was born in 1971. He went on to live for, I would say, 12 long years, up till 84. Unfortunately, he died at that age, but then his life was absolutely not normal. He was called famously the bubble boy because, as you can see, this boy is inside a bubble. He was maintained for 12 long years in a sterile environment inside a bubble. And this is because he did not have T cells in his body. And had they not kept him in this bubble, he would have died within the first year of his life. What are we talking of is the very serious immune deficiency, the severe combined immune deficiency, often called the bubble boy disease because of Mr. David. He did not have T cells. This is a serious immune deficiency. If you want to really survive, you have to stay in a germ-free environment. And that's not practically possible. So nobody can stay in a bubble for so long, and we need definitive treatment in this situation. So why are T cells so important? Why is it important that if you do not have T cells, you cannot survive? And this is because T cells perform a variety of functions in our body. As you can see, the helper T cells, as presented previously by Dr. Rachna, help B cells to produce antibodies, and antibodies protect us against bacteria. However, the helper T cells also activate macrophages, and these take care of intracellular pathogens like mycobacteria, fungi, and viruses. And the killer T cells take care of the viruses, and they have tumor surveillance. It would naturally mean that if you don't have T cells, or if you have a serious T cell deficiency, you cannot fight the bacteria, the mycobacteria, fungi, viruses, and you may even develop tumors. So basically, a child with a serious T cell deficiency is like a culture bottle. You give any organism, it will start growing and create serious infections. So a severe T cell deficiency would result in B cell dysfunction. So many occasions, B cells may be present in these children, but they would not function because of absence of T cells, and you get hypogammaglobulinemia resulting in bacterial infections, and they also have opportunistic infections with viruses, fungi, and parasites. So why do we call it the combined immune deficiency? The word combined here is used because T cell defect results in B cell dysfunction. So you don't have T cells and B cells don't work. So the B cell numbers may be normal. If you do a B cell count, it can be normal. Yet many of these patients have hypogammaglobulinemia, and that's why it is called the combined immune deficiency. Now, what is severe combined immune deficiency? As the name itself suggests, this is severe. So this is a severe form of combined immune deficiency. They often present in early infancy, within the first 6 months of life. And these are usually universally fatal. All children will die before the age of 2. And that's why I said this is medical emergency. So let's take up a case. 7-month-old girl from Bangalore who came to us with severe pneumonia was hospitalized. She also had oral thrush. As you can see, the chest radiograph did show pneumonia, but then interestingly, in this infant, the thymic shadow was missing. We all know that the thymic shadow is very prominent in the first 2 years of life, and the thymus was missing in this child. The hemogram showed neutrophilic leukocytosis. So the admitting diagnosis was severe pneumonia with septicemia because of neutrophilia. However, please have a close look at the differential counts. N is 90, but the lymphocyte percentage here is only 8%. And the absolute lymphocyte count is 1200. So this is lymphopenia. Any lymphocyte count of less than 3000 in an infant is lymphopenia. And this severe lymphopenia in an infant with infection means only one diagnosis, and that is severe combined immune deficiency, a serious immune deficiency. But we can all diagnose this condition just by thinking about this condition and looking at the differential counts. So please look at the differential counts. Please look at the lymphocyte counts. If you pick up lymphopenia, it is nothing but severe combined immune deficiency. So severe combined immune deficiency is a disease that you see in young infants. They come to us with severe pneumonia, often caused by Pneumocystis jirovecii. So they have significant hypoxemia. They can have oral thrush. They often fail to thrive. And because it is a fatal disease, you will see families coming to you with history of sibling deaths. The first and the second child died at the age of 6 months and 9 months, and the third child is brought to you. That is a typical scenario of a severe combined immune deficiency. Suspicion on our part, a close look at the differential counts, lymphopenia there, chest radiograph not showing you thymus, you know this is severe combined immune deficiency. Now, let us go a bit deeper here. Lymphocytes. There are 3 types of lymphocytes: the T cells, the B cells, and the NK cells. In a normal individual, in a healthy individual, 70% of lymphocytes would be T cells. That would mean if you take out T cells, 70% of lymphocytes are out, you develop lymphopenia. And that's why absent T cells causes lymphopenia, whereas absent B cells or NK cells usually would not cause lymphopenia. And commonly we use flow cytometry to enumerate the number, and then there are markers on these cells which help us enumerate the number. So commonly T cell is CD3, B cell is CD19, and the NK cells is CD56. Now continuing the same case, as you can see, this child who had severe pneumonia, oral thrush, because of lymphopenia, we thought this is severe combined immune deficiency. We investigated further, did a serum immunoglobulin profile. All the immunoglobulins were undetectable. We got the lymphocyte subsets. As you can see, the T cell here is 13%. Normally it should be above 40%, T minus. B cells were also low, B minus. However, NK cells were present. So this is severe combined immune deficiency, which is T minus, B minus, and NK plus in this child. Please remember, T cells are absent in most or almost all children with severe combined immune deficiency. So severe combined immune deficiency by definition is seen in children below the age of 2 with less than 20% CD3 positive T cells, or an absolute lymphocyte count of less than 3000, and at least one of the defined mutations. So you'll need a genetic test to confirm the diagnosis. However, to suspect, to screen, you don't need a genetic test. Let us take up these 2 cases and understand the concept very clearly. Case scenario 1 is 6-month-old boy who is unwell from 3 months of age, oral thrush, pneumonia, and a fundus check showed CMV retinitis. So as you can see, fungal infection and a viral infection in a young infant. A 5-year-old boy who comes to us again being unwell from the age of 1 with oral thrush, molluscum contagiosum, pneumonia, and the fundus again showed CMV retinitis. As you can see in both these children, there is lot in common. However, one is 6-month-old and another is a 5-year-old boy. So the type of infections that you saw in these two children are CMV, the Candida, and the molluscum. So all these are opportunistic infections. So T cell defect is very, very likely in both these cases. However, the difference is the first child started being unwell from the age of 3 months and is presented to us at the age of 6 months. This is severe combined immune deficiency. The second child who has survived beyond the age of 2 is likely a combined immune deficiency. And this differentiation sometimes is important because kids need urgent, the children with the first group will need urgent bone marrow transplant. A 4.5-month-old boy, pneumonia, very first episode, thriving well, and the pediatrician calls me and says, I'm referring you an immune deficiency. Now that's interesting because here there are no clear warning signs. This is the first episode of pneumonia. Should we really investigate? But when a pediatrician calls, I'm sure there has to be something significant. So the family history was significant. The first child had died in his hospital at the age of 5 months with severe pneumonia. No diagnosis was arrived at in the first child, and that is why was the concern in the second child. When we investigated the second child, the child had lymphopenia, low T cells, and this is severe combined immune deficiency. But since this child was diagnosed quite in time, he was not very sick. The family was counseled, and we could perform the genetic testing. As you can see, the whole exome sequencing here showed pathogenic mutation in the common gamma chain gene, confirming this to be X-linked SCID because 2 boys were affected. So the mother agreed to be the donor and we performed a bone marrow transplant and the child is doing fine. So this was one of our first bone marrow transplants in severe combined immune deficiency. But the message here is very clear that early referral because of a positive family history helped us treat this child in time. So this 5.5-month-old boy from Nagpur presented with oral thrush, fever and rash for the past 1 month. This rash was very interesting because it was a papular rash throughout the body. We thought, could this be eczema? But the rash was very prominent. So we got a dermatology consult and a skin biopsy. This rash, when biopsy, did show some granulomatous changes, but interestingly, flooded with AFB. The skin biopsy was flooded with AFB. This is acid-fast bacilli. This was in fact disseminated BCG. And we now know that disseminated BCG is known to present and cause cutaneous manifestation with a papular rash. So in a young infant with pneumonia, such a papular rash, when you see AFB, this is very unusual, and disseminated BCG definitely meant an immune deficiency. So we got a lymphocyte subsets. As you can see here, the T cells were only 2%. The NK cells were low. The B cells were present in this case. This is T minus B plus NK minus SCID. So we can see SCIDs can come in various combinations. B cells, NK cells may or may not be present, but T cells are usually low, and disseminated BCG is an indication to screen for immune deficiency. So SCID is a pediatric emergency. We need to perform an urgent hematopoietic stem cell transplant in these children. And if diagnosed at birth or within the first 3.5 months of life, a BMT can be life-saving, and although these children can be transplanted later, but earlier the transplant, better is the outcome. So this slide will highlight the entire concept of SCID, that when you see persistent diarrhea or recurrent pneumonia, failure to thrive, opportunistic infections in infancy, and a positive family history with early infantile sibling deaths, simple investigations can click the diagnosis like lymphopenia, look for absent thymus, lymph nodes may not be seen, tonsils may be absent, and by performing the lymphocyte subset assay, and if the T cells are missing, you know this is severe combined immune deficiency. So this algorithm would be useful for all pediatricians. Clinical suspicion on our part, CBC showing lymphopenia, get a chest X-ray that shows absent thymus. You can confirm it by performing an ultrasound neck. Go and perform the lymphocyte subsets and serum immunoglobulins. Often you would see low T cells, and for confirmation, we perform genetic testing. These children require bone marrow transplant. As again, you can see this is a 9-month-old child who came to us with chronic diarrhea, diagnosed to have SCID, underwent a bone marrow transplant. Another child with SCID who underwent a bone marrow transplant, and these are doing fine. So the next few cases or 2 cases would be very much interesting and similar to SCID, but we don't end up getting a diagnosis of SCID here. Looks like SCID, but the genetic test said something else. Let us see why. This is a 5-month-old girl who came from northern Karnataka. had ear discharge at 1 month of life, severe pneumonia, hepatomegaly, and elevated raised liver enzymes. So we thought because of ear discharge, because of pneumonia starting at such a young age, we thought this is likely an immune deficiency. Hypogammaglobulinemia was there, and then even there was lymphopenia. So I was quite sure that this is severe combined immune deficiency. But there was hepatomegaly, which we could not really explain in this baby. And when we performed the genetic test, to a surprise, we got a mutation in SP110 gene. This is what is called the VOD, the hepatic veno-occlusive disease with immunodeficiency. So this is another immune deficiency that will look like SCID, but then they would have even liver involvement because of the veno-occlusive disease. And only a genetic test can confirm such a diagnosis. Now, it is also important to remember that it is not all about the numbers. I kept on saying that the T cells are low, you think about severe combined immune deficiency, but it is not just the numbers, the function matters. So even if you have T cells and if they don't function, then you are going to have serious infections. This is 1.3-year-old boy from Yemen, came with recurrent pneumonia from 3rd month of life, oral thrush, but to add to it, motor delay and absent sweating. Absent sweating was very peculiar. In fact, the family said that the last child who died at the age of 2 also had absent sweating. So we were quite sure that we were dealing with a genetic disease, and absent sweating is something, a significant finding in this patient. However, looking at the recurrent pneumonia starting from a young age and the oral thrush, I thought this could be a T cell defect, possibly SCID. So we performed an immunoglobulin profile, but this was something very different. This patient, in fact, had hypergammaglobulinemia. The IgG was 2988. Normally, at this age, it should be in between 300 to 1000. So basically, hypergammaglobulinemia, high IgA, IgM, and very high IgE. And so we're not pretty sure what we were dealing with. And when we performed genetic studies, the whole exome sequencing showed a novel mutation in STIM1 gene. This is STIM1 deficiency. What do I mean by STIM1? Let us see. One must know that T cells in our body, although they are present, when they face pathogens, they get activated. So antigen presenting cell, something like a dendritic cell, will present the pathogen to the T cell. The T cells get activated. Unless they get activated, they cannot fight pathogens. So T cell activation is a very, very important step. Now for the T cell activation, you have several pathways, and one of the important pathway is the calcium channels. So here is the ORI1 channel, which causes the calcium influx, and the STIM1 protein. And these proteins play an important role in release of calcium in these cells, which is very important for T cell activation. So basically, these patients cannot have activation of T cells and they have serious infections. But interestingly, these calcium channels, it is a channelopathy, and calcium channels are very, very important, as we all know, for skeletal muscle function. And that is why these patients have myopathy and had motor delay. And these calcium channels are important for sweat gland function. And that is why this patient had absent sweating. So it's basically a syndromic PID with absent sweating, motor delay, and a T cell defect. Again, a genetic test helped us diagnose and pick up this case. So the message here would be that infants with severe infections, please think of a T cell defect, a severe combined immune deficiency. Always look at the lymphocyte counts in a sick infant. Unlike the B cell disorders which present late, T cell defects often start early. Family history of sibling deaths, think of immune deficiency. Earlier is the referral, better is the outcome, and bone marrow transplant is life-saving in many of these patients. This is our team of pediatrics at Aster CMI. Proud to say one of the largest departments, I would say possibly in the country. And this is my number, and I would be happy to take up questions. Thank you.
Thank you, Dr. Sagar. It was very highly simplified version, and what we can understand everything. Actually, I think everyone must be feeling from tomorrow onwards in the OPD, we will start suspecting immunodeficiencies in our patients. You made it so simple. Should we proceed to the next speaker directly?
Yes, ma'am. I think we'll do that. Let Dr.
Okay.
Avinash speak, and then we can take up.
Then we can take the questions. Over to you, Dr. Avinash.
Thank you so much, ma'am. I would like to thank the Maha IAP for providing me this opportunity. And I would like to thank Dr. Sagar in particular for the same. I would also like to congratulate Maha IAP for this interesting concept of mentor-mentees, which helps bring these challenging topics and makes them simpler. So I'll share my screen. Is my screen visible?
Yes, it's visible. Sir.
Okay. And I'm audible. So after we have had these interesting discussions on B cell defects and combined defects, I'll be dealing with the other arm of immune system, I would say, which is the phagocytic arm or neutrophils, which again is an important part of our immune system, and defect or dysregulation in this system also results in inborn errors of immunity. So what I'll be doing is again discussing some cases, and I'll highlight the fact that merely on the basis of numbers, that if you carefully look at the numbers, we can diagnose many of these cases of inborn errors of immunity. So what I'll try to highlight is that numbers are really important. Both increased and decreased numbers of neutrophils help us diagnose these diseases, and these numbers provide really important clues to the diagnosis of inborn errors of immunity. And as has been highlighted in the previous talks, once we start recognizing these conditions, once we start recognizing the patterns, it is really not that difficult to diagnose these conditions or pick up these conditions amongst all the cases that we have in our clinics. The most important is the suspicion. As Dr. Sagar said, once we start thinking about these disorders, we'll really be able to pick up these disorders. So moving on to the cases, this is the institute where I work in. It's a government medical college in Himachal Pradesh, Dharamshala. Many of you must be aware, a place where a beautiful cricket stadium is located and the land of Holy Dalai Lama Ji. So moving on to first case, we have had a 5 weeks old girl, a very young infant, 5 weeks old girl, virtually a newborn. She presented with redness around umbilicus, which was there for 2 weeks, and an ulcer over the palate, which parents noted a day back. She was referred to us from another medical institute. There was no history of fever, no history of lethargy or poor feeding in this baby who was born to non-consanguineously married parents. She was exclusively breastfed, and because she had redness around the umbilicus, the resident asked about the shedding of cord, which the parents noted that it was shed at 3 weeks of life. In the family, she was the only child of non-consanguineously married parents. On examination, we found that the child was well thriving. This redness around the umbilicus was noted. She had stable vitals, and as you can note, there was this ulcer over the palate. And when we investigated this child, we found that the hemoglobin was 12 grams and a highly total leukocyte count more than 100,000, 127,000 per millimeter cube of total leukocyte count, with a differential of polymorphonuclear leukocytosis, 60% polymorphs, with an absolute count of more than 75,000, absolute neutrophil count of more than 75,000, and platelets of 450,000. So the highlights in this hemogram, a simple hemogram, are markedly raised total leukocyte count with predominant neutrophils, with the history of delayed separation of cord. On examination, omphalitis was found. So this suggests a diagnosis of leukocyte adhesion deficiency. Merely on the basis of some clinical symptoms and a hemogram, a clinical possibility of leukocyte adhesion deficiency was made, which was confirmed by flow cytometry, where CD8 expression on neutrophils is reduced in patient. This is the patient, the lower panel, and this is control. If you can carefully see these pictures or graphs, you will see in the control, this thing has shifted to right. This thing has shifted to right, and this suggests that about 99.9% neutrophils are expressing CD18, and this is the patient where you hardly see any shift. So there were hardly any CD18 positive neutrophils in this patient. The diagnosis was confirmed by genetic analysis, where a mutation was found in the relevant gene. And this patient was published as a palatal ulcer in LAD, which is an unusual occurrence. So once this patient was diagnosed about 3 years back, the residents became more aware of this condition. And in following 1 year, 3 more such cases followed. And as you can see, the age of presentation was ranging from 4 to 20 weeks, There was a history of delayed cord fall in 2 of them. No family history of any one of them. All had omphalitis and all had ulcers. So this suggests a pattern. Omphalitis with ulcers which are non-healing. There was no pus in the ulcers. So this pattern suggests a diagnosis of leukocyte adhesion deficiency. As you can see, all of them had leukocyte counts well above 50,000 with neutrophilic predominance. So neutrophilic leukocytosis, which is very high, really high total leukocyte count with an absolute neutrophil count of virtually more than 50,000, normal platelet count with these non-healing, ugly-looking ulcers. A diagnosis of leukocyte adhesion can be made with such ease. Merely on the basis of hemogram, one can suspect the presence of leukocyte adhesion deficiency, which can be confirmed by flow cytometry and genetic analysis. Interestingly, all the 4 patients had same mutation, and all of them belong to the same geographical region of Himachal Pradesh, a single district of Himachal Pradesh, though there was no consanguinity in any of them. And with these patients, we were able to be part of these large publications. One, as Dr. Sagar highlighted, we were part of this collaborative effort of leukocyte adhesion deficiency. So leukocyte adhesion deficiency, as the name suggests, is a defect in adhesion of leukocytes to the endothelium of vessels. So there is a defect in this adhesion, and because there is a defect, and this defect can involve many of these molecules. So defect or deficiency in any of these molecules will result in defective adhesion, which will result in impaired mobility towards the site of injury or infection. So neutrophils fail to reach to the site of inflammation or infection, and therefore the peripheral number of neutrophils increases by large numbers, whereas they do not reach the site of infection, and that is why there is no pus at the site of infection. So when do we suspect leukocyte adhesion deficiency? As we have seen, recurrent bacterial infections of skin and also respiratory tract and intestinal tract. Impaired wound healing, a very important feature of leukocyte adhesion deficiency. You will almost always find large non-healing ulcers in these patients. Absence of pus formation is another hallmark because neutrophils do not reach that site. There is absence of pus. Delayed separation of cord you may find in many of them, and marked polymorphonuclear leukocytosis even in the absence of infection, again as a hallmark. If we find these features, then it is not difficult to make a diagnosis of leukocyte adhesion deficiencies. There are certain types. Actually, there are 4 types, and type 2 is identified by a peculiar blood group, and in type 3 there is a tendency to bleed. There is a bleeding diathesis along with recurrent infections. So when do we think of leukocyte adhesion deficiency? Whenever we see marked neutrophilic leukocytosis. If we are discussing numbers, whenever we see marked neutrophilic leukocytosis, think of leukocyte adhesion deficiency. Now, another common primary immunodeficiency disorder where neutrophilic leukocytosis is seen is chronic granulomatous disease, which is much more common than leukocyte adhesion deficiency is. So moving on to the next case, who is a 4-year boy, symptomatic since the age of 2 years. So for last 2 years, the child has been symptomatic with recurrent pneumonia, or I would say persistent pneumonia, which failed to resolve and failure to thrive. The father worked as operation theater technician with an orthopedic surgeon. And when he had pneumonia for the first time, which did not resolve with routine antimicrobials, which he was given, someone decided to try antitubercular therapy, which was given for 6 months, did not make any much difference. The child again, or rather he continued to have these symptoms, and then subsequently, again, someone decided to give antitubercular therapy. By this time, the child started developing, he already had persistent pneumonia, he started developing osteomyelitis of rib. A biopsy was taken from there, granuloma was noticed, and then antitubercular therapy was started thrice in this child. He, as I told, he started having rib osteomyelitis and vertebral osteomyelitis. When presented to us, these lesions were found of osteomyelitis. A simple hemogram revealed total leukocyte count of 32,000 with again neutrophilic leukocytosis. Platelets were also increased with an increased ESR. So increased ESR, persistent pneumonia, someone suggested that anti-tubercular therapy must be given, which he had already received. Immunoglobulin, now looking at this child, he fails to recover completely with antimicrobials, anti-tubercular therapy, and he continues to have that persistent pneumonia. So there has to be some defect in the pathogen clearing mechanism, that he's not able to clear these organisms or whatever he is having. So we decided to move ahead with immunoglobulin profile, which revealed immunoglobulin G of more than 2,500, IgM of 174, and IgA also elevated. So elevated IgG and IgA. As already highlighted, elevated or high immunoglobulins are also not good. Pan-hypogammaglobulinemia or hypogammaglobulinemia we have seen in patients with XLA, CVID, SCID, but elevated levels of these immunoglobulins may also suggest some underlying immune defect. So this is a classical example of chronic granulomatous disease where you find granulomatous inflammation. So we suspected CGD. We went ahead with, again, a very simple test, nitroblue tetrazolium test, which is a dye-based test where we stimulate the neutrophils with simple yeast, and then we look at the change of color of the dye. If the color of the dye changes from yellow to blue-black inside the neutrophils, then it suggests a normal person. But if the yeast is engulfed, as you can see, but there is no color change, this means there is no respiratory burst in the neutrophils and the neutrophils are not acting properly. This suggests a diagnosis of chronic granulomatous disease, again confirmed by DHR or dihydrorhodamine assay, which is also a respiratory burst assay. So this confirms the diagnosis of chronic granulomatous disease. Chronic granulomatous disease is a defect in this respiratory burst of the neutrophils, which again involves many proteins, many molecules. So defect in any of these will result in different varieties of chronic granulomatous disease. X-linked CGD or GP91 defect is the most common of them. We can also have autosomal recessive CGD, which are less common. Chronic granulomatous disease is also characterized by signature organisms that are found in these persons which are affected with CGD. So whenever we have a patient who has fungal pneumonia, especially aspergillus pneumonia, always rule out chronic granulomatous disease. Recurrent staphylococcal infections, recurrent staphylococcal abscesses, one must rule out chronic granulomatous disease. Whenever we have deep-seated abscesses, even the first episode of deep-seated abscess, a liver abscess, brain abscess, we must rule out chronic granulomatous disease. Certain signature organisms, as I already told, aspergillus, if we have nocardia infection, Burkholderia, Serratia, even the first infection with these organisms, chronic granulomatous disease must be ruled out. If we have a patient with recurrent lymphadenitis, suppurative infections, recurrent pneumonia, especially fungal, deep-seated abscesses, as already discussed, osteomyelitis of small bones, vertebrae, rule out chronic granulomatous disease. So these are the patterns which we must remember, that whenever we have a patient who is having recurrent suppurative infections, we should think of phagocytic defects. Either absence of pus formation or more of pus formation, think of phagocytic defects. Now, we also must know that all granulomas are not tuberculosis. As we all know that there are many other causes of granulomatous inflammation. If we find granulomas, they may not be tuberculosis always. So CGD can have granulomas, as the name suggests, chronic granulomatous disease. Prolonged fever, pneumonia, again, hallmark of CGD, also found in tuberculosis. Lymphadenitis, a feature of chronic granulomatous disease and also of tuberculosis. So whenever we don't find AFB or evidence of tuberculosis, we must think of other causes of granulomatous inflammation as well. Moving on to the next case, which is a 4-year-old boy, first born to non-consanguineously married parents, symptomatic since 8 months of age, recurrent episodes of abdominal pain, fever with oral ulcers, again submandibular abscess twice. So recurrent pyogenic infections. Another highlight is oral ulcers or ulcerative manifestations. Ulcers, pyogenic infections, think of phagocytic defects. When investigated, we found that TLC was 5,000. And if you look at differential count, carefully look at that, the neutrophils are only 9%, absolute neutrophil count of 450. So this means he has neutropenia. because he was having these infection manifestations for long, he had past records with him. And when we carefully looked at those past records, we find that he hardly ever had neutrophil count which reached 600. So the neutrophil count hovered around the value of 500. So this means he is having persistent pneumonia, persistent neutropenia. Bone marrow was done, which showed maturation arrest at the promyelocyte stage. No lineage was seen beyond a promyelocyte stage, and this confirms the diagnosis of a neutropenic defect. Treated with GCSF, and after we started GCSF therapy, the neutrophil count improved markedly, and he stopped having those infections and recurrent fever and oral ulcers. The next case is a 3-year-old girl born again to non-consanguineously married parents, symptomatic since 1.5 years of age, with recurrent episodes of ear discharge, again oral ulcers, cutaneous ulcers. As again, I'm highlighting the fact that ulcerative manifestations and pyogenic infections think of phagocytic defects. Hemoglobin was on the lower side, total leukocyte count 6,800 with an absolute neutrophil count of 272. Again, when we looked at the past records here, we find a different pattern. We find that sometimes the child is having a neutrophil count which is low, below 500, and at other times she's actually having absolutely normal neutrophil counts. And this shows some trend. Again, a bone marrow was done, which showed maturation arrest, and the genetic mutation confirmed the diagnosis of cyclic neutropenia, where we have, in cyclic neutropenia, we have these the low levels of neutrophils every 3 weeks. So every 3 weeks, you will find a trough level. And during these trough levels, the patient is likely to have infections, oral ulcers, gingivitis, fever, periodontitis-like manifestations. How do we confirm the diagnosis of, or how do we suspect rather a diagnosis of cyclic neutropenia? Whenever we suspect cyclic neutropenia, what we do is we do hemogram twice for a period of 6 weeks. So in any 6 weeks period, you expect to have 2 trough levels, because every 3 weeks we have a trough. So in any period of 6 weeks, you are likely to have 2 trough levels. So this is how we suspect cyclic neutropenia, and then we do bone marrow or straight away the genetic mutation. Management again is with GCSF and hematopoietic stem cell transplantation. The next patient is an 8-month-old boy who is again born to non-consanguineous parents, hospitalized with pneumonia, and he has been hospitalized twice with pneumonia in last 2 months, and he was not responding to IV antimicrobials, so was sent to us. Here again, the pedigree chart, you will recall the pedigree charts shown by Dr. Rachana. This suggests some X-linked history and a positive family history or a relevant family history is extremely important in the diagnosis of PIDs or inborn errors of immunity. This is one of the most important points which help us pick up the PIDs. As Dr. Sagar also highlighted, some pediatrician referred a patient with the diagnosis of PID only because one of the earlier sibling had died. So a positive family history really helps in the diagnosis of primary immunodeficiency disorders. The X-ray was suggestive of pneumocystis pneumonia in this child. This child, if you recall, is having infections for last 2 months. He has been hospitalized thrice, not responding to IV antimicrobials. The X-ray is suggestive of pneumocystis pneumonia. So IV cotrimoxazole was initiated and he responded. Now the causes of pneumocystis jirovecii pneumonia. We all know that this pneumocystis pneumonia is an opportunistic infection most commonly seen in patients with HIV and severe combined immunodeficiency. So we went ahead with these tests. HIV was ruled out and the lymphocyte count was normal. So he has 73% lymphocytes out of 8,300, but the absolute neutrophil count is 830, which is on a lower side. When we did immunoglobulins, what we found was IgG was on the lower side, IgA was on the lower side. However, IgM was elevated. If you recall one of the cases discussed by Dr. Rachana, this is hyper IgM or X-linked hyper IgM, confirmed by flow cytometry, reduced CD40 ligand, and we confirmed the diagnosis of X-linked hyper IgM. X-linked hyper-IgM, as already discussed, is a defect in class switching, usually presents in infancy with sinopulmonary infections, but also has opportunistic infections. So another important differential in a patient with pneumocystis jirovecii, whenever you have a pneumocystis jirovecii pneumonia in a boy, because it's an X-linked disorder, X-linked hyper-IgM. So whenever you have this pneumonia in a boy with negative HIV and normal lymphocyte count, think of X-linked hyper-IgM syndrome, in which neutropenia can be seen in up to 70% of patients. So for these patients, we learn that numbers are really important. If you carefully look at numbers, if they're really high or even low, if the values of immunoglobulins are high, they really help in diagnosing these patients. Both increased and decreased numbers of neutrophils provide important clues. In fact, leukocyte adhesion deficiency and severe congenital neutropenia or Postman syndrome can be ruled out merely on the basis of these counts. If the counts are normal, you can rule out leukocyte adhesion deficiency. If neutrophil count is normal, you can rule out Postman syndrome. And the other important primary immunodeficiency disorders where numbers really help are CGD and hyper-IgM syndrome. This is the team that I work with. Thank you so much.
Thank you, Dr. Avinash. It was a wonderful presentation. All three of you has literally enlightened us about the immunodeficiency. Now we'll go for question answers. There are many questions in the chat box also. We'll start with that. One of the questions says, what is the treatment for leukocyte adhesion deficiency?
Dr. Avinash sir, please stop sharing. Please stop sharing, Dr. Avinash sir.
Okay. Okay. So the treatment for leukocyte adhesion deficiency is, as for many of immunodeficiency disorders, is bone marrow transplant. And if done, it really helps. In fact, one of the first patients that we saw during our residency in whom bone marrow transplant was done was a patient of leukocyte adhesion deficiency. The bone marrow transplant was done elsewhere and the patient was doing good. So treatment of choice is bone marrow transplant.
This serves for lifelong, that is, bone marrow transplant helps.
Yes.
Throughout the life?
Yes. In this case, it serves for lifelong. Unlike many other primary immunodeficiency disorders, IVIG or immunoglobulin therapy usually does not help in leukocyte adhesion deficiency. Some people have tried, some people do give immunoglobulins around these lesions or ulcers. But in this leukocyte adhesion deficiency, the treatment of choice, and rather I would say the only treatment that is available is bone marrow transplant, which serves for life.
There is one more question from Dr.
I would like to add here, because you said, does it serve lifelong? We need to also answer one more question that people often think that when we do a transplant, there is a lifelong immunosuppression that you see in solid organ transplants, like kidney transplant or a liver transplant, unlike which in bone marrow transplant, we are able to stop all medicines practically by the age of, by 1 year of post-transplant period. That is really a life-changing event. If everything goes well, you are practically off all medications by 1 year post-transplant.
There is a question from Dr. Pramod Kulkarni sir. How do we classify hyper IgE syndrome? And another question is GI and liver manifestations common in CGD combined.
Okay, so I would like to take up the question of GI and liver manifestations. They are actually common. The question says GI and liver manifestations common in CGD. Yes, they're actually very common. The GI manifestations can be in the form of colitis, which is a common manifestation of chronic granulomatous disease. And liver abscesses are also very common, which like the patient I discussed of CGD, the liver abscesses also fail to resolve with any kind of treatment. So liver and GI manifestations are really common. Sometimes we suspect CGD merely on the basis of colitis. So colitis is an important manifestation. Liver abscess again is an important manifestation.
Rachna, you want to answer on the classification?
Yes, sir. So hyper IgE syndromes broadly classified as autosomal dominant and autosomal recessive. The autosomal dominant one is that which we all commonly know is the Job syndrome. that is the STAT3 deficiency. Whereas the autosomal recessive, there are several genes defined, but what we commonly discuss is the Dockade deficiency.
Okay. One more question was added after this. Do these patients have acute catastrophic episodes? Do they suddenly collapse? Any one of you can answer?
No, usually not. Usually not. They usually do not collapse suddenly, as you would see, possibly comparing with a child who has got an arrhythmia. No, they usually do not collapse all of a sudden because they present to us with infections most often, although they can come with autoimmunity and malignancies. But I don't see why they should suddenly collapse.
One more question says, it's Dr. Nitesh Chaudhary asking, is lymphopenia always suggestive of SCID?
So I'll take up that. Lymphopenia is the very, I would say, characteristic feature of most of the patients with severe combined immune deficiency. But having said that, there are several causes for lymphopenia. Viral infections can cause lymphopenia. Children with DiGeorge syndrome can have lymphopenia. Even there is a lot of discussion of lymphopenia in COVID times. As we all know, adults with COVID who had severe disease had lymphopenia. Patients with MISC had lymphopenia. So I think there are several causes for lymphopenia. But in a given context, that means when you are dealing with an infant coming to you with infections, you look at the lymphocyte counts, which is often neglected because we often concentrate on the neutrophil counts, because we often diagnose these children to have septicemia. So that is the context is very important. And second thing, we always say persistent lymphopenia. It's not a single record. I often say you give antibiotics, the child seems to get better, but the lymphopenia is persistent. You know that this is likely severe combined immune deficiency.
Dr. Sagar, just extending the question, does a normal ALC rule out SCID?
I was waiting for that question, sir. No, a normal ALC does not rule out SCID. So life is not that simple as we make it simple on these slides. So yes, lymphopenia is a characteristic feature, but we do have scores of patients with SCID where you don't get lymphopenia. We call them as the hypomorphic SCID because of the mutations that you see, you may always not get lymphopenia. So while lymphopenia is helpful, but if I see a child coming with oral thrush, Pneumocystis jirovecii pneumoniae, and even if the lymphocyte count is normal, I would proceed and investigate further. So normal lymphocyte count does not exclude SCID.
Dr. Rajendra Chandorkar wants to ask, if we pick up SCID earlier and do bone marrow transplantation, is the disorder completely curable? I think you already answered the question. The second question says IgG are produced through IgM. So what about IgA and IgE?
No,
I
so
think I'll take up the question, ma'am.
Yeah.
It is basically class switching that helps in conversion of IgM to IgG, A and E. So what is formed from the plasma cells is initially the IgM, and through a process known as class switching is what we get the other immunoglobulin levels.
Dr. Pramod Kulkarni has asked, does hyper IgM syndrome have IBD as common presentation?
Colitis and
Irritable bowel.
Irritable, inflammatory bowel.
Inflammatory bowel. Yeah.
Autoimmune manifestations are defined in hyper IgM syndrome. That is, patients with hyper IgM can have various autoimmune manifestations, especially hematologic manifestations, arthritis, IBD. They also have organ-specific autoantibodies, but it is not the most common presentation.
Okay. Sir has asked one more question. When do we suspect autoinflammatory syndrome?
Autoinflammatory syndrome is, I think, a class in itself. We can have another one. But broadly speaking, autoimmune diseases, we all have studied for past, I would say, 4 or 5 decades. We all know about autoimmune diseases, the classical example being rheumatoid arthritis or systemic lupus. In the last 2 decades, more and more has been discussed with autoinflammatory disease, especially this decade, new diseases have been added. So to give a broad principle, we know in autoimmune diseases, you get autoantibodies like the anti-nuclear antibody. That is because your adaptive immune system, like the T cells and B cells, are reacting to our own antigens. That is autoimmune disease. Now we all know, like the adaptive immune system, there is something called innate immune system, neutrophils, macrophages. So imagine a situation wherein neutrophils are producing a lot of cytokines which are causing tissue damage. So it will look like autoimmune disease, but there are no autoantibodies most often, because it is an innate immune defect and you get what is known as autoinflammatory disease. Classically, to make it simple, I would say periodic fever syndromes, which we discuss, where every month a child has periodic fever, oral ulcers, Those are the autoinflammatory disorders. But the list is quite long and we need to really discuss them in depth.
There is one suggestion by Dr. Pramod Kulkarni, autoimmune or endocrine associations to suspect IEI. He has suggested these links are to be noticed. Dr.
Rachna, we'll take up that, ma'am. I think
Huh.
there are diseases which can have autoimmunity and endocrinopathy.
Okay.
Dr. Rachna, you want to take up?
So, sir, I think you can take it up. I'll add.
Sorry. Yeah. So basically, one should know that we were talking about autoimmunity as a manifestation of a PID or a immunodeficiency. But if you get polyautoimmunity, especially having multiple autoimmune manifestations in a given patient, like we have had patients with arthritis, ILD, patients with colitis. So if you have multiple autoimmune manifestations, we start thinking of a genetic defect, number one. Number two, if the autoimmunity is starting at a very young age, if you see somebody having SLE before the age of 5, invariably this is a primary immune deficiency or a genetic disorder. Right. Plus, if you have patients coming to you with polyendocrinopathy, like a patient having hypoparathyroidism, hypothyroidism, vitiligo, so multiple autoimmune manifestations, we definitely think of immune deficiencies. Now, classically, just to give you some names, we have disorders where like the LRBA deficiency, CTLA4 defect. So we are having now group of diseases wherein you have autoimmunity and endocrinopathy. So for all the endocrinologists and ped endocrinologists, it's important to know that they need to think of these diseases.
Sagar, you opened up a Pandora's box. SLE coming in early age group, you will have to work for the things, genetic PID. Now, can you tell us which are the markers? We do see SLE. At times, I've seen a smallest one being 3 years. Recently, we picked up 5 years old. So, do you really go for NGS for this patient for immunodeficiency? And what are the markers of immunodeficiency in such kind of children?
Okay, sir. So number one is when lupus starts below the age of 5, it is an unusual occurrence. I am sure, sir, if you have seen many lupus
Agreed.
patients,
Agreed.
Below 5 is not something that we see in day-to-day practice, number one. Number two is one of the common immune deficiencies that even I had worked up as my MD thesis was a complement deficiency. Complement C1q is the first protein in the classical complement pathway, and this C1q deficiency is known to present with early onset lupus. Their typical features would be not only lupus, but they have infections with encapsulated bacteria. So they may have pneumococcal sepsis to add with. They usually have a negative anti-dsDNA, whereas the anti-ROLA antibodies are positive. And if I want to make it interesting, you know that the complement pathway starts with C1q and then progresses down. So if C1q is missing, the pathway is not activated. So C3, C4 are not consumed. So classically, I say in lupus, you should have low C3, C4. Here, the C3, C4 would be normal. So early onset lupus, normal C3, C4, negative anti-dsDNA, positive ROLA. So those are the features. But this is only one. The list is long. Now, another example would be the type 1 interferonopathy, the Aicardi-Gouttiere syndrome. Now, that is also considered to be a lupus-like disease wherein you have a lot of CNS manifestations. So to make it simple, you think of torch when you have calcification in the brain. You should always think of Aicardi-Gouttiere in that setting. So a child who has got intracranial calcification with skin lesions, chilblain lesions, hepatosplenomegaly, think of early onset lupus. So that could be another possibility. We have a child who has got strongly positive ANA, arthritis, looks like lupus, but has got skeletal dysplasia, short stature. Now, this is a new form of newly described disease, what is known as the Spence CD. This is another form of early onset lupus. But basically, whenever it doesn't suit you, starts early, have additional infections, additional manifestations, think about these diseases.
Will you just give few words about this newer entity, autoinflammatory disorders? I mean, lot has been discussed only, and it's totally new to the common pediatrician. So just brief, when do we suspect, and some kind of a markers where we can, further proceed.
So in autoinflammatory disorders, the problem is that it is not a single disease. Right now, there must be more than 30-35 well-defined monogenic disorders, and the list is long. The first simple example would be recurrent fevers. So if you see a child coming with episodic recurrent fevers with elevated inflammatory markers, that is the first point I would start thinking of a periodic fever syndrome or autoinflammatory disease. These patients, along with prolonged fevers, can have severe pain abdomen, and that is because of serositis that they have. They can have periorbital puffiness. and they can have myalgias, so non-specific symptoms. You can think of an autoinflammatory disease. Now, we all know about Behçet's coming with recurrent orogenital ulcers. If the Behçet starts at a young age, it is again usually a monogenic autoinflammatory disease. I was talking about Aicardi-Gouttière syndrome, the CNS form of lupus with intracranial calcification, is another autoinflammatory disease. So the problem is I cannot really say, yes, this is the thing. Recurrent episodic fevers, sterile inflammation, pyoderma gangrenosum like presentation. So there is a varied presentation for autoinflammatory diseases.
Just one more question commonly asked by everybody. In a critical child, how does the criticality confound your investigation? So do we send it at that phase, or will we send it now and repeat again, or send it after 3 or 6 months only?
So I think this is a very standard question that I think in every meeting I have done, I have got this question because people are concerned when the child is sick in the ICU, should I investigate or should I wait? As Rachna rightly answered, we must investigate. There are confounding factors. Now, if you have a child who is very sick, the lymphocyte subsets may go haywire. You may get lymphocyte variations, aberrations, but there is no reason you will get 0% T cells. So if you get very, very low T cells in a sick child, you know this is severe combined immune deficiency, and this child may not give you another 3 months. This child may not even survive for the next 3 months if you don't diagnose it then. And that is why we must investigate. Now, when the values are very borderline, you are not very sure, don't give a label. Let us put it that there were aberrations. We are going to repeat the test after 3 months once the child is better. That can always be done, but we must investigate when the child is unwell.
Dr. Sagar.
Clear.
Hello. Madam, I want to ask one question.
Okay.
Dr. Sagar, if we often miss the immunodeficiency, particularly B cell defect, because it is evident at the age of 6 months onwards. And in that case, if we offer a patient a live vaccine, say polio vaccine or measles vaccine, what is your take on this?
So live vaccines are generally contraindicated in patients with B cell defects, especially because polio vaccine is known to be associated with vaccine-associated paralytic polio. So if one knows that this child has got a B cell defect, we avoid OPV, not only in the child, but even in immediate family members. Because the other problem these patients have is that if they get OPV, the live virus, it doesn't get cleared. And we have now literature to show that these patients shed the virus for months and sometimes years. And we all know more the virus circulates, more it mutates. And that is why you get VAP, VDPV and all that. In fact, currently there is a project going on in India, a multicentric project where we are looking at polio virus excretion in immunodeficiency patients. And this is because we now know that we have eradicated polio, but then VAP and VDPV are the challenges. And we believe the PID patients may be the reservoirs for this virus.
Yes.
That's why we should avoid OPV in a patient with a B cell defect.
But it is again government program, this say pulse polio. It is given in masses, na? So how we can avoid this?
Yeah, so it can only be avoided if you have the diagnosis. I would say if a patient is, for example, if I have a patient with X-linked agammaglobulinemia, I write on their paper saying that OPV to be avoided in the child and the family members, and the family is counseled. Right. So that is how it works.
Thank you.
Dr. Sagar, do you adequate this immune deficiency assessment, screening test? It is recommended or not?
Newborn screen.
Newborn screening, you're saying. Sir, newborn screening is something which is right now standard of care in the US, in all the states. Newborn screening for SCID, severe combined immune deficiency. They do something called TREC assay, and they pick up these babies right at birth and transplant them early.
Right.
So in an ideal setting, yes, we should do a newborn screen. For India, I think we are little far, sir. We should get it some in years to come. But right now, I don't know if the, more common disorders like hypothyroidism have been screened right, left. Every child is a child being screened. So I wouldn't be justified to say that every child should be screened for SCID at this moment. But yes, in days to come, we will have those programs in hand, because we should also have protocols ready for definitive testing. If you screen them, screening test is positive, you should have facilities to make definitive testing. You should have facilities to transplant them. So I think those are parallel moral, ethical questions that also arise with the screening.
Dr. Sagar, taking that question further, You mentioned the incidence is 1 in 1200 collectively, I suppose, those 430 disorders which you mentioned. Now, I want to know how many of them, are they all life threatening? Or few of the milder version, the child can get along even without doing anything? I mean, how many of them are really something which you really immediately require to do something? And I mean, is that critical? Like why with newborn screening is, it has to be cost effective. Like hypothyroidism is 1 in 500 to 2000 in this country, and one single disease. Here we are talking about 430 disorders, making collectively 1 in 1200. So, I mean, how many of them are really life threatening?
To answer that question, sir, no, not all are life threatening. Disorders with severe T cell deficiencies would be life threatening, especially SCID and SCID like diseases would be life threatening. The other group of diseases will not be life threatening. The other thing is, we cannot have one screening test for 430 diseases. That is another challenge.
That's
So
right.
whatever screening I told was for SCID. Now, SCID, they say, is as common as 1 in 30 to 1 in 50,000. Previously, they said 1 in 50,000, but because of the screening program, they started picking up asymptomatic babies. So it went down to, say, somewhere close to 1 in 30,000. So that is the number for SCID. Yes, in India, it would be a challenge to right now provide the screening program, but a serious immune deficiency, ideally, I think needs to be screened at birth. But we do not recommend doing random screening, and there is no single screening for all 430 diseases.
Nilima madam, there are some questions posted from YouTube to this. Just go ahead.
There is one question from Dr. Ramakant Patil. He is saying, I have seen 4 patients with hypogammaglobulinemia with normal SSA managed with IVIG for 1 to 2 years, and all 4 were off IVIG and growing well for years. What is the natural history of immunodeficiency?
Yeah, that's a very, very interesting question. Now, number one thing we need to understand is that there is something called transient hypogamma of infancy. So normally between 3 to 6 months of life, we have very low globulins, which is physiological, but it kind of resolves beyond 6 months and in majority by 2 to 4 years of age. So if somebody picks up a low IgG at the age of 1 and starts IVIG, and after 2 years, if you stop IVIG and you say that, yes, I've cured the immune deficiency, I wouldn't take that. I would say that possibly the diagnosis wasn't right, or it was basically a transient hypogamma of infancy. The true immune deficiencies, like for example, X-linked agammaglobulinemia, they would not get cleared on their own. They will need monthly IVIG for life, or you perform something like a definitive bone marrow transplant. That is the natural course, that these children would have intercurrent infections. Globulins which are low tend to remain low.
There is one more question from Dr. Ramakant Patil. Is it possible to predict who can get cytokine release syndrome?
Yeah, so you have disorders like perforin deficiencies and HLH. So we can predict that these people can develop cytokine release syndrome. You have patients with systemic GIA who can develop cytokine release syndrome or macrophage
activation.
So basically the word CRS is like a broad umbrella word where you have several terms now, like you have cytokine storm syndrome, cytokine release syndrome, MAS. And I think the term actually has come up with CAR T cell therapy, which is for cancers, where you really use the word cytokine release syndrome.
Dr. Sagar, I have one question.
1 minute, Jay. Finish that question. Finish that question. Nina, madam, finish the YouTube channel questions.
Yeah, Dr. Yamini Sharma wants to ask whether all vaccines are contraindicated in CID.
Rachna, you want to take that? Vaccinations in PID?
No, or not all vaccines are contraindicated. When we talk of T cell defects, live vaccines need to be avoided. Killed vaccines can be given. And like sir highlighted, in B cell defects, we avoid the live vaccines like oral polio vaccine.
And in fact, there are diseases like complement deficiencies where we would like to give them vaccines. We would like to give them vaccines for encapsulated pathogens.
Yeah.
Yes,
that question is done. There was one question from Dr. Jain. He was asking, all multiple wards patients should be investigated for immunodeficiency.
Patients coming with wards, especially if they are multiple generalized, usually along with some other infections, I would tend to investigate them, because usually it would mean a T cell defect. One of the common diseases that we have seen with generalized wards would be the Dockett deficiency, the hyper IgE syndrome. Another disease which I haven't seen but we read theoretically is the WIM syndrome, where you have wards, hypogamma, immunodeficiency and myelokathexis. So yes, especially if you have recurrent warts, generalized warts, and many of these patients have additional viral infections like molluscum, we tend to investigate them.
There is one more question. Selective IgA deficiency is said to be commonest PID. So when to suspect it?
So I think the data of selective IgA deficiency being very common comes from Scandinavian countries and those group of countries. In India, although we have published so much data, we don't see a lot of IgA deficiency. Selective IgA deficiency by definition would mean very low IgA, less than 7 milligram per deciliter. So most often these patients may be asymptomatic or they come with recurrent sinopulmonary infections or basically recurrent sinusitis, recurrent otitis media. And even these patients are predisposed to autoimmunity. For example, celiac disease. We all know that we do IgA levels because patients with IgA deficiency can develop celiacs. So yes, these patients can come with autoimmunity and usually milder infections in the form of upper respiratory tract infections. But I believe it is not the most common PID, at least in Indian settings.
Do you advise bone marrow transplantation in the patient of agammaglobulinemia? Monthly IV gamma द्यायची त्याला bone marrow transplant काय करायचं आणि what is the cost of bone marrow this transplant in our country?
If you say cost effective way would be to do a bone marrow transplant, because one time you would spend say around 20 lakh rupees, whereas giving monthly IVIG for life would definitely be more costlier. Speaking medically, the standard of care for most of these patients is still IVIG, like for patients with X-linked agammaglobulinemia and CVID. Having said that, there are centers in the West and there are even centers in India who have performed transplants on XLA and CVIDs.
Yeah.
So I think it has to be taken with a pinch of salt, case-to-case basis. If you have a full match sibling, that can be offered, but I would still believe that the standard of care right now is IVIG infusions.
Sagar, just one question related to IVIG regular use in these patients. Now, I'm taking the analogy of say hemophilia. When the factor level goes 0, 3, 5, maybe at times even at 1, and the child is quite comfortable, and we don't give any factors. So when he actively starts bleeding, and I detect the levels to be so low, I give. Otherwise, normally he should be having at least above 50%, but even 5% don't bother me unless he starts actively bleeding. If that is taking that analogy to even IVIG, the IgG levels in the plasma, why we need to give them periodically every 1 month? I mean, if he catches infection, I'll give IVIG. Why should I give it continuously? So, I mean, is there anything you can explain that?
Yeah, correct, sir. I think the patients also ask us these questions because it is not a simple therapy. It comes with significant financial constraint. The answer to that is we give IVIG replacement therapy, sir. So we are replacing something that is missing. It is, to me, the analogy would be insulin. If I don't give insulin to diabetes patient is with 400 sugars, why bother? Let his kidneys get affected and then I start treating. So the same thing applies here, because when these patients come to us, become very sick in the ICU, get ventilated, we can definitely give them IVIG, but knowingly I've pushed him to the ICU. So it is the prevention of such infections that is what is the purpose of giving IVIG. I can also take an example, an unfortunate example of a child with X-linked agammaglobulinemia who had low immunoglobulins, and they said take protein mixture and the immunoglobulins would become okay. This child unfortunately developed septicemia, peripheral gangrene, and both the limbs have to be amputated. Now, if you ask me, was the IVIG worth it? 200% worth it, because now this child is crippled for life and does not have those two limbs. And for a simple disease like XLA, where the parents can actually afford IVIG, but nobody could really put an effort to say that, yes, you have to take IVIG every month. So it is a preventive therapy. Basically, the purpose of IVIG is to prevent infections. And obviously, when they come with infections, we will have to still give them additional doses of IVIG.
Do overuse of antibiotics or missing immunodeficiency in our India?
Yes, B-cell disorders, they survive into adulthood. That is because of the usage of antibiotics. Now, the T-cell disorders don't survive long, the serious ones, because they get viral fungal infections and they die. But the B-cell disorders, as Dr. Rachna presented, have pneumococcus, H influenza. They will easily respond to antibiotics. And that is why they keep on getting infections and survive into adulthood.
There is one more question in the chat box from Dr. Ramakant Patil. IgA deficiency patient, if receive IVIG, may develop anaphylaxis. What's the mechanism, and whether pure IVIG without trace of IgA will prevent it?
Yeah, that is a good question, and that is also a theoretical question. It is true, because if you have a selective IgA deficiency, we say they may have anti-IgA antibodies, and if you give IVIG containing IgA, they can develop anaphylaxis. But truly speaking, in our clinical practice, we hardly see this. We also do not really see selective IgA deficiency. There are certain brands, memory beats me, but there are certain brands which can give you IgA free IVIG. There are brands you can have them, but if you ask me practically, I have never had an occasion where I have to use that brand.
Do IVIG transmit HIV infection?
No, sir. There is not a single report of HIV being transmitted by IVIG. That is because of the stringent measures that they follow during production.
Yes, one case was shown by Dr. Rachana was related to arthritis of X-linked gamma globulinemia. What is the mechanism?
Rachna, you want to take up?
Yes, sir. So arthritis in GI in X-linked A gamma globulinemia patients is often missed, considering it as JIA, because these are actually infections, and they're prone to infections such as mycoplasma, ureaplasma, which we usually don't isolate on our tests. That is why they go undiagnosed for several months, but actually they are suffering from infections.
Okay, so it's an infective
arthritis, mycoplasma or ureaplasma.
It's an infective arthritis.
Yeah,
Why it does not progress? In fact, he's an immunodeficient patient. Why it does not progress rapidly?
I wouldn't say it progress, because I don't have clear answers to that, but they basically have this often oligo, sometimes polyarthritis, and we have seen them responding to azithromycin along with IVIG. But it is not that simple, because these patients, especially the CVID ones, can even have autoimmune arthritis for that matter. So XLS, we know it is more common mycoplasma, whereas in CVID, if a patient comes with arthritis, it is most often autoimmune, wherein I may have to even use steroids along with IVIG.
Okay.
There is one more question in the chat box asking, have you seen any adverse reaction to IVIG in long run?
Not in the long run, but yes, we have seen immediate reactions to IVIG. Some patients having chills, some patients having breathing difficulty. Fortunately, no life-threatening event that I have seen, but yes, they can have immediate adverse reactions. No long-term side effects that I have seen.
And I think if the questions are finished, my last question will be for all over Maharashtra pediatricians who are listening. If we suspect immunodeficiency, whom to send the patient or refer the patient? Where are these?
I think you are blessed in Mumbai, ma'am. You have the National Institute of Immunohematology,
we have
Wadia Hospital. Dr. Mukesh Desai is there. So I think you have enough resources in Mumbai. But what we really need to go is go beyond Mumbai and shout louder in several districts of Maharashtra, and for that matter, the whole country. Because what we are really diagnosing now is practically, for me, nothing. I mean to say, we are going to diagnose 1,000 more times of these patients once pediatricians on the ground start picking them up.
Correct.
One more question. Dr. Ramakant Patil says it is more of CVID than antibiotics taking B cell immunodeficiency patient to adulthood, isn't it?
I don't get the question. Sorry.
Nilima ma'am.
Yeah. Is it more of CVID than antibiotics taking B cell immunodeficiency patient to adulthood?
CVIDs, yes, survive into adulthood on their own, but then I'm sure if a serious pneumonia would not have received antibiotics, the patient would have died.
Right.
So I think there is a contribution. The defect is milder. It is not like SCID, and that is why they survive. But yes, our usage of antibiotics does change their natural course.
And I think next question, Avinash Sharma sir has already answered in the chat box. So should we wind up the session?
Yes.
The concluding remarks will be given by Dr. Mohite sir. Sir, over to you.
Yeah. Well, I'm sure this is a cracker of a session to start our mentor-mentee. All of us will agree. Immunodeficiency, such a volatile topic, but these new generations of Dr. Sagar and his kind of things have at least made us sense that there is some kind of an entity. The question, I mean, the real thing is think of it, suspect it every now and investigate. I'm sure in next 1 month in Maharashtra, the investigation for immunodeficiency will go to the peak. But in subsequent 1 month, unless we have another session by Sagar, the investigation level will go down. Many of us would think that, is it really that common? Now you think that we have missed so many. While going through your lectures, I was wondering how many I have missed over the years. In fact, today itself, I have seen one child who was treated 2 years ago, or I think 2 years ago with transverse myelitis, a very affluent child, came with a thumb, only thumb is having fungus-like lesion. I sent it to the dermatologist, and that's going on for almost last 1.5 years. I was wondering whether I missed something in that. So I'm sure we have missed so many. But your talks, all three of you, give wonderful presentations, a variety of cases. They may be covering maybe 70-80% of the immunodeficiency. Let that 20% be for the super experts. Even if you look at the early common, we should not miss the skid. I think message is very, very clear and loud that look at those counts. If the lymphocyte count is less than 3,000 in the infant or less than 1,000 in bigger child, suspect. If the neutrophil count is less than 500 or 600, suspect. If those platelets are going haywire without any explanation, suspect. I suppose just simple messages. All of us are doing CBC definitely to almost all your admitted patients. Even if you take those simple take homes, they will make a lot of things. Our only just to suspect and guide it to the right person. I think beyond certain things, yes, I think we have become much more wiser in doing immunoglobulin levels, and those facilities are quite common. The lymphocyte substrate analysis is available, CH15 is available. So basic 3 investigation, the lymphocyte substrate analysis, to IgG, IgM, the total immunoglobulin levels, and the CH50. That's a basic screen once you have a primary suspect. And believe me, they are very cheaply available at KM. I suppose they're costing hardly 4,000 rupees. It's a very cheap investigation. So you start suspecting, send those parameters appropriately. When you seriously suspect, repeat those maybe after 2 or 3 months, and you will be at least not missing the significant one. And what is something which is life threatening, as Dr. Sagar said, a skid, at least that is something which we should not miss. Thank you, Dr. Sagar. Wonderful disposition. Dr. Avinash and Dr. Rachana. That was wonderful presentation, and we are very, very happy to have the first session in our mentor and mentee. I'm sure this will take us a long way. Thank you very much.
So this was the first Friday release of Maha Mentor Mentees. We are going to have such 8 more first Friday of every month. Only the 2 months where Friday is in view of the overlap with the general journey. It will be on Saturday. And for a presentation, there is a thank you from Nagaland also, yes. Sir. So somebody attending from Nagaland also. And we have lots of dignitaries on the dais, but just one comment I will take, because Rajendra Vaidya always commented on this webinars. So just I will request Dr. Rajendra Vaidya, past Maha IP president, to comment, and then we'll go to the vote of thanks.
Hello, good evening. Excellent, Sagar. I have missed my OPD to attend your session. Definitely, it's a great learning experience, as Mahesh told. We have missed so many cases. Definitely, yes, wonderful. And your 2 colleagues are also, Rachna and Avinash Sharma. They were also excellent. Definitely, congratulations, Hemant, Mahesh, and all, and other madam, all Maha IP team. Amol, you have done excellent job, and I think now we'll have to sacrifice my Friday at least for 1 month to attend all this session. Excellent, congratulations. Sagar, only one question I want to ask. In first go, leukemite reaction versus LAD. Can you give some?
Leukemite reaction versus LAD, sir.
First,
yeah. So one thing is, I think even Dr. Avinash can take up. Leukemoid reaction is something that you see sometimes even due to serious infections, but LADs have a typical profile. Number one is the delay in cord fall that you see in many of these patients. And as Dr. Avinash rightly said, those non-healing ulcers, that is one thing. And somehow, I don't know, but whether you have, I will ask you, sir, a count of 1,20,000, a count of 1,30,000 with 90% neutrophils. So that is something that is very characteristic of LADs, which I personally haven't seen even in leukemoid reactions.
Yeah, it is around 50,000, 60,000, 70,000 like that. Yeah, definitely.
You will often see counts crossing a lakh and almost all neutrophils. So that is what it is. Avinash sir, if you want to add. Yeah.
As you said, the classical presentation with those non-healing ulcers, the absence of pus. If you find delayed cord fall, there is no other differential. And as Dr. Sagar said, I think if you have counts beyond 100,000 and almost all of them neutrophils, you think of LAD before leukemoid reaction. So in the context, I think it may not be difficult to make a diagnosis of leukocyte adhesion deficiency, especially if you see those non-healing ulcers.
Even in between infection in LAD, there is a leukocytosis.
Yes,
Yeah.
yes.
This is one of the, you can suspect it is the LAD1.
If by any chance one gets to do the hemogram in between infections,
Right.
yes, you will find neutrophilic leukocytosis.
I think that's a very important point, sir, because their leukocytes come down, but they never normalize.
Normal, right?
Hmm.
And simple CBC gives many clues of the all immunodeficiencies, right?
Yeah, definitely.
So,
And the auto-inflammatory spectrum now increasing. I think SOJ is also now in the auto-inflammatory disorder, though they are classifying. Am I right, Sagar? Is it
Yes,
clear?
yes, they put them under autoinflammatory diseases. Yeah.
Thank you,
So-
thank you. Congrats. Excellent, Jerry.
So
Thank
if I can pronounce properly, Dr. Akum Toshi is also here. He can comment if he wish.
From Nagaland.
Yeah.
From
Nagaland,
Nagaland.
huh?
Yes, doctor.
Yes, sir. Yes, sir.
Hello, sir.
Yes,
Good
sir.
evening, sir.
Good evening.
I am Dr. Akam from Nagaland, the IAP State Branch Treasurer. It was an excellent talk, a very eye-opening talk indeed. And it brings to our notice how many things and how many patients we have missed out with. And I think this again is a very, very big learning experience. And thank you all of you for this wonderful session. Thank you all of you.
Thank you very much. Thank you very much. Yes, Nili madam.
Now it's time for Thanksgiving. Over to Dr. Amol Pawar, Secretary, Maharashtra IAP.
It was a wonderful session. I thank all the speakers, mentor Dr. Sagar Bhattat sir and mentees, Dr. Avinash Sharma sir and Dr. Rachna Shanbag for their elaborative, informative lecture on primary immunodeficiency, which will help in day-to-day practice to all general pediatricians to pick up such cases. I also thank Dr. Mohite sir and Dr. Nilima ma'am for coordinating this session. And I also thank all the attendees on Zoom and YouTube for their kind listening. On behalf of Maha AP, I assure you all to have many more such trials in as mentor and mentees in coming months. Thank you, one and all.
Thank you. Thank you. Good night.
Thank you very much.
Thank you.
Thank you.
Stop live streaming, madam. Live streaming stop.